So thanks for the introduction, Deanna. Yes, I am a postdoctoral fellow at the University of Alberta. This is my 3rd year in that position, but I have a lot of ties to UVic. It's my academic home. I did my PhD there, completed it in 2011, and in 2012 I joined iPANEL as a co-investigator. So that's kind of my link with the project. Now, let's see. I'm just going to go to the next slide, hopefully. Okay. So because we're meeting virtually, I thought I'd just put a picture of myself up here. In case we ever have a chance to meet in person, you'll know what I look like and you can say hello. This is a selfie that I took of myself using my iPhone when I was in Tofino. I'm absolutely freezing cold in this photograph because it was on the shores of Long Beach, but it's one of the most recent photos, so there you go. So just by way of introduction of the presentation today and an outline, I'm just going to start by discussing a few key terms in my work and introduce and make connections with the iPANEL project. And then I'll talk about some of the findings from the first phase of my postdoctoral study, which was really a pilot focused on feasibility of using iPads with renal patients in hospital clinic settings. And I'm currently in the second phase where we're collecting data in 2 different cities using iPads, again with renal patients and with mixtures. And I'm just going to talk about how this is unfolding, an opportunity for questions. So just a few key terms as way of background to the population that I am working with and that I'll be talking about, and just a few clarifications about conceptual terms as well. So I would say, like in a really broad sense, my overall program of research focuses on life-limiting illness and health-related quality of life. And I have a particular focus in chronic kidney disease, which is on the slide here as CKD. So CKD typically affects older adults. In Canada at this time, there are over 40,000 people that are on dialysis. And in this photo that's on the screen, you'll actually see a woman who is hooked up to a dialysis machine. And when someone goes for hemodialysis in a hospital like this woman is doing, conventionally people go for about 3 to 4 hours every second day. And chronic kidney disease isn't often thought of as a life-limiting illness, even though for people that are on dialysis, in Canada, only 43% of them will still be alive 5 years after starting their therapy. And what's actually really, this is often really surprising to people. What really floors many is that for renal patients who are 65 years and older, their mortality is twice as high as patients in the general population who have cancer. And kidney failure is actually, kidney disease is ranked as the 10th cause of all deaths in Canada. So we don't often think about this illness in these terms. This is one of the things that's kind of behind the scenes and undiscussed, even within the renal community, but it certainly is life-limiting. And even for those that have a life-limiting illness such as kidney disease, of course, everyone has the right to dignity. And so given that everybody has the right to a good quality of life, we use the terms quality of life and health-related quality of life a lot, but it can be quite abstract. So by health-related quality of life, what I actually mean is the value that a person gives to their life when they're living with an illness or an injury or treatment, and then how this is influenced by their perceptions or their impairments or their capacity to function in life. So in other words, it's really the person's subjective view of the impact of the illness on their life. So in thinking about patient-centered care and attending to people's reports of their own illness, particularly terminal chronic conditions, this is what I'm doing in my study. But it's also certainly pertinent to a palliative approach, which is the reason that many of you are possibly here today and joining in. So just by way of, I guess I should add as a disclaimer, I do not have a palliative background, so I just want to say that from up front, I want to provide just a little bit of background to the iPANEL project. Some of you online may know this, and you maybe even able to share it better than I will, but some of you may not. So the iPANEL project is the Initiative for a Palliative Approach in Nursing, Evidence, and Leadership. And Kelly Stadjahar from UVic and Carolyn Taylor from Fraser Health are the leads on this project. And the research question is this: how and in which context can a palliative approach better meet the needs of people with chronic life-limiting conditions and their family members, and guide the development of innovations in healthcare delivery systems to better support nursing practice and the health system in BC? The big question is, what is a palliative approach? So it takes the principles of palliative care and it applies them to the care of people with life-limiting chronic conditions. And as I had said earlier in my one slide intro to kidney disease, you can certainly see how that can be applied to a renal population. The second bullet here identifies that a palliative approach doesn't link the provision of care too closely with prognosis, but there's a much broader focus on conversations with people and their families and their needs, the support that they identify that they need or information they want, and then as well, provision for death and care after death. So it's very much how I think about this is very much an upstream approach, broaching conversations really early on in the trajectory and not waiting until a healthcare team thinks that a person may be technically palliative. And just in thinking about that, I guess another important idea about a palliative approach for me is that when we as healthcare professionals, that we need to acknowledge that there may be, I guess, certain aspects of living with death that may be hard to talk about and may even be irresolvable for patients and possibly for healthcare professionals, even if these discussions begin early on in the healthcare trajectory. So it's important that we have these conversations often, frequently, looping back to them many times over. So I guess going back to a broader perspective is that the palliative approach really recognizes that not all people with life-limiting conditions require specialized palliative care, but they do require care that's aimed at improving the quality of their life. And for me, this is a very significant link, particularly because conceptually, I've been looking a lot at quality of life, and I think that there's fabulous linkages between this and people who live with illnesses that are life-limiting. So I think one of the hallmarks of this iPANEL project is connection with practice. So the research is informed by and informs clinical practice, and practice leaders co-lead this project. So through research, iPANEL's goal really is about creating new knowledge about how nurses can further integrate palliative philosophies and services into all types of different non-specialized settings, which provide end-of-life care. So so that's like kind of a brief overview of iPANEL. So I'll tell you about some of the linkages that I see between a palliative approach and the kidney population. So in renal disease, the conventional focus has really been on extension of life through dialysis. So successful treatment uses advanced technology, particularly dialysis. And it's a huge commitment for people. When they start on hemodialysis, it's at least 3 times a week for 3 to 4 hours on the machine. If they're at home, it may be more. If they're doing dialysis at night, it could be 8 hours a night. If they're doing peritoneal dialysis, that's every day. So it certainly is a large time commitment. And once you start dialysis, if you withdraw, death will likely follow 4 to 10 days later. So I'm going to go just to that second bullet there by Davison in 2009. Sarah Davison is a nephrologist from Edmonton, at the University of Alberta, and she wrote this: many renal patients experience a slowly progressive decline in functional status, and patient, family, and care providers are often unable to identify a phase in which the patient is clearly recognized as dying. So that identifies that there is no clear-cut, often palliative phase, that this transitioning is much more fluid and invisible to many patients and to many healthcare providers. There's another study that Dr. Davison did, and I have the reference for where that article is, with 584 kidney patients who are either on phase 4 or 5, diagnosis stage 4 or 5 of CKD, meaning they were either pre-dialysis or dialysis, or potentially in conservative management. And when they were asked, 60% of them regretted their decision to ever start dialysis in the first place. And less than 10% reported that they had had discussions about end-of-life care issues with their nephrologist in the past 12 months. And these are quite startling statistics for this population. And I know it's not representative of the whole, but in this study, it's a very strong message. The Robert Wood Johnson Foundation has articulated 11 years ago that there is a culture of death denial in the renal population, and that's systemically, like within healthcare as well as within conversations with patients. And I guess the other thing is that in looking at linkages with palliative is that the majority of renal patients do not access palliative care services, even if they go through a withdrawal of dialysis and go towards conservative management. So the linkages are strong, but often not clearly apparent in how we, I guess, conceptually think about palliative care. So I just want to transition now from that kind of like overarching broad statement about linkages between the population and iPANEL and talk specifically about the study that I am doing right now. So the title of my project is Health-Related Quality of Life Assessment in Clinical Nephrology Nursing Practice. And I'm very blessed to hold a highly competitive postdoctoral fellowship from Crescent, and you'll see the full name of that title on the slide there. And at this time, I am the only nurse in Canada to hold a fellowship from Crescent. It's usually given to nephrologists and to basic scientists. So this has been a really fabulous opportunity for me to bring nursing to the table, where national priorities in nephrology research and in innovations are planned and discussed. And so through Crescent, I received funding from Canadian Institutes of Health Research, Kidney Foundation of Canada, Canadian Society of Nephrology, and I have quite strong financial support from the Faculty of Nursing at the University of Alberta as well. And so that's why you see all of their emblems on my PowerPoint slide there. So just going to the next slide to tell you a little bit about the first phase of the study. So we know from previous research that health-related quality of life is a direct predictor of morbidity and mortality in end-stage renal disease. And so with I'll just back up for those non-renal people out there. End-stage renal disease means that people are at the latest phase of kidney failure, so they're either on dialysis or they're on conservative management. So even though health-related quality of life is a direct predictor, measurement in clinical practice is quite rare. So I'm trying to attend to this gap in my study. So there's two phases in this project that I'm leading, and the first phase is a pilot study that was completed in 2013. So my research question is on the slide here. Is it feasible to administer and score health-related quality of life and symptom assessment measures using iPad in outpatient home hemo and peritoneal dialysis clinics? So I conceptually defined feasibility as patient satisfaction with the process of completing surveys on an iPad, and then also the time for completing these questionnaires. So operationally, this meant that patient satisfaction and the time needed to complete these questionnaires needed to be studied and analyzed. And so this is what I did in this phase. In looking at the methods, I used a deductive cross-sectional observational study design, and I was at every outpatient clinic in Victoria and Nanaimo for a 3-month period. And every person who met the inclusion criteria were invited to participate. So if they participated, it meant that there were 3 surveys that they completed. The first was the Kidney Disease Quality of Life 36, and this was collected online and then stored on a US database. And if any of you techies are out there who have worked with the US database before, your ears may have perked up, because yes, I indeed did have to attend to all the intricacies of the US Patriot Act, and I'm happy to discuss that more if any of you have questions about it, but I'll leave it there for right now. So the second survey was the Edmonton Symptom Assessment Scale, or the ESAS, and the third one was satisfaction in using a tablet computer. And these were both newly created iPad apps, and they were created by Doug and Patrick, who are shown in their picture on the slide right now. And just a note that both the ESAS and the QoL are considered EPROMs, or electronic patient reported outcome measures. And there's been a very strong international movement towards routine incorporation of PROMs into healthcare service delivery. So there's, I guess, conceptually linkages between EPROMs and the type of work that I'm doing. So one of the things that's important when you're looking at using technology and translating from paper surveys to electronic surveys is the notion of measurement equivalence. So I'm going to talk about this, these tech issues just on this slide. So we can't assume that when we translate from paper to electronic that they're equivalent, but the extent of our modifications will determine what evidence we actually need to test measurement. So in my study, I had really minor modifications, meaning instead of like circling a number 1 with a pencil, you clicked on a number 1. So I have the full reference here for a seminal article here by Coons et al. For anyone that is interested in this. But according to them, with minor modifications, there's 2 things you do: usability testing and cognitive debriefing. So usability testing is really about a formal documentation about respondents' ability to use an electronic platform and to follow instructions and to answer the questions that we ask them. So to attend to this, I documented participant satisfaction with using the tablet computer, and there was a 3-question survey about this. And I also had timestamps built in so I could see how long it was taking people to complete it. And then for cognitive debriefing, this is, as you would probably assume, this is when you interview people about their understanding of the items, or like what came to mind when they answered the question. So every person in this study was also interviewed about completing the questionnaires on this using the iPad. So there were 56 participants in this study, and in total in 2013, in these 2 cities, there were 83 people who were attending the outpatient clinics. So overall, that was a 68% response rate, which is pretty good. And when you look at their demographics, those who were 65 years and older made up 59% of the respondents. And they ranged in age from 36 all the way up to 91 years old. And there were more men than women, which is quite typical in this population. And 82% were retired due to age and disability. So you can clearly see that this is an older adult population that was a part of this study. And because this was Vancouver Island, there wasn't a lot of ethnic diversity, with 91% identifying as Caucasian. 71% did not have diabetes, and 87% were on a specific type of dialysis called peritoneal dialysis, and that's in the green pie chart there, identified as PD. And the only other demographic I want to point out was that only 2 of the 56 people had ever used a touch screen tablet computer before, and this is important because it's a confounding variable that couldn't be controlled. And I was really interested in feasibility and what patients thought about providing their information electronically to healthcare providers. So that's where that comes into play. So to answer my big question, the participants are really satisfied. 67% said that they were very satisfied. And 2 people, you'll notice, were on the other end. They said they were very dissatisfied. But the interesting thing was that when I interviewed them, they said actually they really enjoyed it. So it leads me to believe that perhaps they mixed up the extreme scores on the scale, and that can be quite common in survey completion. So if you remember back to my question, research question about feasibility of administering and scoring patient-reported outcome measures, my outcome or my dependent was level of satisfaction. And then my independent variables were listed here. But when it came time to looking at correlations with satisfaction, none of the variables listed here were correlated. As a quantitative researcher, you're not super happy with those kind of results, but it's certainly not uncommon to have non-significant results. And John Dewey in 1916 wrote this, and it's very, I think, appropriate in the case like this of non-significant results. He wrote, "The scientific experimental method is a trial of ideas. Hence, even when practically or immediately unsuccessful, it is intellectual, fruitful, for we learn from our failures when our endeavors are seriously thoughtful." So this is certainly encouraging for anyone like me who faced something like this. So, but it still left me with this question about why were patients so satisfied? There wasn't any explanation statistically. So some ideas that I have about this are that when the iPad app was designed, it was designed for an older adult. So it had large font, no graphics, and really clear directions. The second thing was that I showed them how to use the iPad, and I assured them they couldn't break it unless they threw it across the room, and I encouraged them to touch any button they want. I could navigate them back. And I guess the third thing is that I actually sat in the waiting room with them the whole time, and so I was there for help if it was needed. So I guess the second and the third item highlight a potential performance bias, meaning that my assistants could really be an intervention that influenced their ratings of their satisfaction. But in looking back, I don't know that I would do it any other way, because only 4% has ever used this type of tablet before, or a tablet before. And so most of them would not have participated in the study. So certainly this is a limitation that needs to be acknowledged in relation to internal validity. I think it's really important that as researchers that we recognize that our presence can also be an intervention. So one of the unexpected findings in the study is that when people were completing the questionnaires, it really facilitated engagement with their community. So to make that a little bit more transparent, when I was in Nanaimo, there's only one main waiting room in this area, and that's where I worked. And a lot of participants commented to me that they actually hadn't spoken with another patient before. And I thought this was really odd because I actually saw people exchanging emails and going out for coffee after their clinic. So I thought it had always been like this, but I found that wasn't actually the case. So when I was there interacting with them, what I found was that patients started interacting with each other, and so a sense of community began to grow. And word got back to the nurse manager, and she actually found out that in Victoria I hadn't been in the waiting room. So she asked that I move from kind of a side room into the waiting room so that patient community could be impacted in a different way. So that was certainly an unexpected finding. So just in conclusion about this phase, it certainly is feasible to administer health-related quality of life assessments using iPads in an environment such as this. Unfortunately, the health authority did not allow access to its internet, and so I ran everything off of a 3G or a cellular platform, which is possible, but certainly not the most ideal. As I previously reported, the reports of satisfaction may be biased, but as electronic devices become more common and as baby boomers enter retirement and their more senior years, I have no doubt that less education about tablets will be required. So in phase 2, I'm really interested in addressing how electronic capture of patient-reported outcome measures can be used in patient care. So this is what we are doing right now. In fact, it's where I was this morning. So the goal is to put patients' electronic reports of quality of life directly into the hands of their nurses. So phase 2 involves both the patients and the clinic nurses as research participants. And I should certainly mention that I met with nurse administrators and clinicians in designing this project as soon as it was funded. So in phase 2, while the clinic nurses are participants, other nurse administrators also participated in the role as research consultants or collaborators. And that's really essential in working towards research practice partnerships. So on the side here, I have my research question. Do health-related quality of life and symptom assessments using iPad improve client outcomes, client satisfaction, and overall health-related quality of life? So my question and my hypothesis is really based on previous research coming from oncology and lung transplantation, which identified that when you had routine assessment of health-related quality of life, the first thing was that communication between patients and healthcare professionals was positively impacted, and they said that their interactions weren't prolonged. The second thing was that healthcare professionals' awareness about patients' experiences was increased, which of course makes sense because the patients were giving them direct answers to what they thought of their own symptoms and their own quality of life and how that was being impacted. And the other interesting thing was that patients' quality of life improved. So that informed my question, specifically looking at what outcomes or mechanisms of action are at work when we have this incorporation into nursing clinical assessment. So for this second phase, we started collecting data on February 5th, and we have 2 more months to go. So it is a prospective cohort design, and we're collecting data again in every clinic in Victoria and Nanaimo for 6 months. So most patients come into the clinic every 3 months. Some of them come in every 2 months. So it means that we'll see every patient at least 2 times, and for some people it'll be 3 times. So the kidney disease quality of life and the ESAF results are given to the patients, and they're also given directly to the nurses. And one of the wrinkles that we had to figure out was that the nurses asked for the results in paper, but we're actually collecting them electronically. Part of it was a system issue because they're not wired in throughout their clinic. So what we had to figure out was how do you actually print from an iPad without an internet connection? And this was actually, surprisingly to me, a huge challenge. So having tech support in a project like this is really essential. And we did figure it out. And by we, I don't mean me. I mean the techies with the brains figured this part out. We also added a patient-reported experience measure, and that is looking at how patients would rank their satisfaction with their care. And also all of the nurses who have agreed to participate in this study are being interviewed. So we've interviewed all of them once, and they will be interviewed again closer to the end of the study, which will be kind of like mid-July. And because this project has expanded in the way that it has, it now takes village. So there's 9 of us, including 3 current graduate nursing students from the School of Nursing at U of A. So when you look at all the people on the screen, the fabulous thing is that there's people with expertise in information technology, public health, social policy, nursing, and one person also, her background was in protein biochemistry. So it's fabulous to have a very diverse perspective. And so this is actually my last slide. In looking at KT knowledge translation of now and then into the future. So the results of the surveys are given to the patients in real time, but one of the websites that I'm using also allows me to access educational information to patients should they want it. So right there in the clinic, if patients say that they do want more information, then we print it and give it to them. When the study will be done and we've completed the analysis, or even, I guess, partially through, we can't wait to the very end, we'll be taking the results back to the home dialysis clinic teams, which are interdisciplinary. We'll certainly be reporting results, likely in person to the RNs, but also we will send them information as well as to all patient participants who said that they wanted the information. And at the beginning of the study, before I even started collecting any data or viewing ethics, actually, I presented to the Vancouver Island Renal Steering Committee, so I'll go back to them to take the results. The other linkage, I guess, that I see about KT and moving forward is that when we're interviewing the nurses about use of the ESAT, one of the, I think, opportunities we have here is to feed it forward, because in BC, all renal patients provide information about the ESAT, and that goes onto a database that is maintained by the BC Provincial Renal Agency. And so I also think that there will be important information that we learn from the nurses about what we are doing and what we could be doing better. And I think it'll be really helpful to inform future research in this area.